Look at me funny.
Sorry.
Censoring.
It's interesting.
Yeah. It's here. So there. I'm going to use a similar technique. So my right hand is the sensor. I think of as it lays on his joint. I think about, okay, this is roughly sacral base, middle joint, inferior lateral angle. All right, can I get there? I'm going to roll off PSIS into that multifidi area. Kind of feeling bulk. It's got good tone there. I'm going to do the same roll here, but now I'm going to do, again, it's going to be very light. You see, I come in here, I'm on slightly on the inferior border of the ASIS, and I'm pushing back, and my force is directed toward my index finger on the sacral base. It's a very subtle angle because it's a very long distance. So if I tilt my hands a little bit, I'm going to move there. If I tilt my hands a little bit this way, I'm going to move back here. So it's not a big angle where I'm pushing up and pushing down. It's a very small vector to direct it toward sacral base. So I'm going to direct it here towards sacral base. And what I'm going to feel for is that the nominate should glide posteriorly on the sacrum. And I'm going to get R1. R1 is when I push. When do I feel first tissue resistance? And then my end feel. How far does it go? Because somebody's been postpartum or they have an expanded neutral zone, you're gonna pick up the expanded R1s here. With the anterior one, you're not gonna pick them up as much because really we're kind of looking for stuck, unstuck is the model. But I want to know how much play this joint has in it, so I know that if they have a low transfer things, they need to land on a single leg, they're a runner. If they have an expanded neutral zone, then their muscular system needs to account for that. Or else it could be that they aren't stuck, but they're getting too much motion and the whole system collapses. So here, as I go to check the middle joint and inferior joint, it's very subtle. See there? See how subtle that is?
Mm-hmm.
I change a little bit where I'm directing toward maybe this finger here, and then I go here, and now inferior lateral angle, but I'm not moving much. It's just a very little bit, but now I can feel the pressure come into my, what is this? It'd be my third finger, my ring finger, and there should just be a little bit of give. If I feel excessive give, where I want to test it, so if I feel that, oh, at the sacral base, I feel like that PSIS really rocks back further than I typically see, or if I feel like, hey, I put my index finger in here and I go right to the sacrum, I feel bone, and there should be multifidi. There should be 1.5 inches of multifidi from what we saw up there between my finger and the sacrum. So go ahead and push your shoulders, put your elbows down by your side. There you go. Go ahead and push your shoulders and your elbows into the bed. You should feel sacral multifidi tone up. I should feel that joint stiffen. Ability of the multifidi to stiffen the joint. I'm going to take your leg here. I'm going to push into my leg. There you go. Go a little bit less. Not so much gluteus, external rotators. When external rotation should stiffen the joint. Should give you the most stiffness, really, because it has the ability to compress the joint across all 3 spans. Go ahead and relax. And again, just let's do a pelvic floor contraction. Draw up and relax. Pelvic floor should stiffen inferior lateral angle. So I'm feeling, okay, this person is hypermobile, and it feels like, wow, it feels like it's down low, and I kind of direct down at the inferior lateral angle. Then I can check the pelvic floor contraction. Can they stabilize when they do that? If that joint is compressed and it feels stiff when I do this, then one of the things I need to then feed out is, do I have a history or incidents that would make me think that they're having some type of hypotonicity problem here to compress the SI joint, create chronic compression, which would create irritation in the SI joint. So I'm looking at my provocative tests. You might go through that cluster, but that's the thing I need to consider. It doesn't give you that information to see. You say, okay, where's my problem? What might it be? Inhibition of sacral multifidi, from chronic back pain, L5S1 disc degeneration. He's not stabilizing the joint. It could be an SI joint involvement, and probably an L5 problem in a secondary SI joint. But more commonly what it's going to be is that as I go to load my leg, this muscle stabilizing system must fire and be intact so I can move forces through my pelvis and into my back and through my leg. If that system isn't coming on in the right timing or sequence, then that's when we talk about like that idea of failed load transfer. Something gives. Is it a valgus of the knee in a jumper or a young female athlete? Is it this hip rotation that goes in there? Any of these things, is it L5S1 starts to get jammed up or hypermobile because now all of a sudden my pelvis is doing this and I'm driving upward through my pelvis into L5. So this is what I want to palpate next. I want you to palpate SI joint. Similar rocking mechanism here. It's got to soften it up a bit and get soft, keep it small. Think about where we are in relationship in the finger, the sacral base on the multifidi, mid joint, inferior joint, and just get a sense of that joint play. Don't beat yourself up until you felt 30 of them.